everyone, and welcome to our third annual Autism Hope Summit. I'm so excited for our next speaker. I know that you're just going to learn so much stuff, and he's going to be talking about something that's just so important to our community. I'd like to introduce Dr. RichardFrye, and today we're going to be talking about autism and seizures. So thank you for being here, Dr. Frye.
Oh, it's my pleasure. Thanks so much for inviting me.
Well, I know this topic is huge, as we know, in the autism community. But before we get started, I want people to know a little bit more about your background and why you're so passionate about helping the autism community.
Sure, yeah. So by training, I'm a child neurologist. So one of the reasons why I seem to know a little bit about seizures. And I have an interesting history of how I got into autism. You know, after doing my training in child neurology, I was actually very interested in learning disabilities, and I did a fellowship in learning disabilities and behavioral neurology. But what I found is the patients that came to me, their children didn't so much have learning disabilities, and this was about the early 2000s, when autism was on the rise, and a lot of parents came to me and said, my child's just been diagnosed with autism. They don't know what causes it. They don't know what to do about it. I think it has something to do with the brain, and you're a neurologist, so maybe you could tell me. So I took it as a challenge.
No pressure, right?
Right, exactly. So I took it as a challenge to try and figure out, you know, what it was about, what caused it, and what could be done about it. And it was very funny because after, you know, that time I did my training, I had my first job and my second job, and at each point, every time I opened up a new practice in academia, that's what the same thing would happen is parents would come to me with their children with autism and would say, you know, I hear you're an expert in the brain and behavioral neurology, and there's this thing called autism, and maybe you could tell me something about it. And what eventually happened is, of course, none of my colleagues really knew how to treat the children with autism. So they heard, oh, you see children with autism? You can have all of mine. And
Wow.
before I knew it, that's the only population that I was seeing of children was children with autism. And I had officially make what I called my medically based autism clinic because I looked at it from more of a medical point of view than a behavioral point of view.
Absolutely. And wow, I mean, I guess there's always a reason for everything. And now you're one of our leading top doctors in autism. And honestly, thankful for whomever kind of pushed you in that direction, because I know you've helped thousands and thousands of families. When we're talking about seizures, I know that they're all not created equal. And so before we start talking about and diving into these questions, I know a lot of families might not really understand even really what a seizure is. So can we maybe give a definition of, you know, what is a seizure?
Sure. Oh, it's a great question, you know, and there's two things, right? There's seizures and there's epilepsy. So I like to talk about both. Okay. Seizures are when the electrical activity of the brain becomes what we call synchronized. So usually all the billions of neurons in your brain are kind of firing, which transmits information kind of randomly to kind of tell each other, you know, different things. But sometimes what happens is they all synchronously fire at the same time, which is very abnormal. And what that does is it kind of shuts the brain down, and the brain starts to have this rhythm of all the neurons firing at the same time. And when what commonly we see when we think about seizures, we think about jerking of the limbs. And that happens when this kind of synchronous activity gets to what we call the motor cortex, the part of the brain that makes your limbs move. And that's why you see if somebody has a seizure, usually you see their limbs jerking in a rhythmic fashion. And that represents this rhythmic, synchronized activity in the brain. And usually what we think about is a generalized seizure. Somebody falls on the floor and they have this rhythmic activity for some period of time, and then it stops, usually within a minute or so, and they have what we call a post-ictal period, where the brain is kind of stunned, and that can last anywhere from minutes to hours. Mm-hmm. So, and that's what we call a generalized seizure, when the whole brain is like that. But sometimes it may be a very small portion of the brain, which we call a partial or a focal seizure. That is, one part of the brain seems to have this abnormal activity and it's not working right. And if that happens to be attached to a part of the brain that controls what we call the motor center that controls your limbs, you may see jerking of one of the arms, one of the legs, maybe the face. Whereas if it's in another part of the brain that affects your thinking or your speech, you can actually see that interrupted for a short period of time. So there's all different types of seizures that can occur. And in autism, we do see every different type of seizure. Many times we see what we call multifocal seizures, where multiple parts of the brain seem to have this abnormal electrical activity. And then we have to also differentiate that, if that's not complex enough, we have to differentiate that from what we call subclinical seizure discharges or epileptiform discharges, which aren't really seizures. They're seizure-like activity that occurs in small parts of the brain, and they're kind of like if you would think of a car, like your car backfiring. So it just, that part of the brain just isn't working for just a millisecond or two, or maybe a second. And it's controversial as far as whether that's really significant to the way the brain works. That is when you have these subclinical discharges. Sometimes if it's in a crucial area of the brain, like the language area, and you have lots of these kind of backfirings in the language area, sometimes we think it is significant. But at other times, it may not be. And that's one of the challenge in treating seizures and also subclinical epileptiform activity. Now, seizures and epilepsy are related, but they're not exactly the same thing. So the definition of epilepsy is to have two unprovoked seizures. So that is, you can have seizures that are provoked because you may have a fever, or you may have traumatic brain injury, or something else. You may have an infection that causes that, and those may be provoked seizures. But if you have unprovoked seizures, and you have more than one, that's a definition of epilepsy. And epilepsy is actually pretty common in the typically developing population. Probably about 8% of typically developing children will have a seizure. About 1 to 2 go on to develop epilepsy. 1 to 2%. Sorry, 1 to 2% go on to develop epilepsy. Most children that develop epilepsy have epilepsy for a very short period of time, maybe a year or two, and it resolves on its own.
Okay.
So in the typically developing population, it can be very benign, that is, and just kind of a hiccup in development. Okay. In autism, it's a little bit different. That is that we tend to see many more children with autism. The rates vary, but it may be up to 30 or 40% of children with autism may have seizures at some point in their life. And they tend to be more refractory. That is, they're harder to treat, and many times they go on for longer periods of time.
And I know that, especially in the autism community, there's different types of seizures where some of the symptoms, and correct me if I'm wrong, where they might just have staring spells, and it doesn't always necessarily be as a child that might shake or fall to the ground. It literally could be a brief 1 to 2 seconds, even longer or so, staring spell, and then they go on about whatever they were doing. So that also could be a seizure type activity. Is that correct?
That's absolutely correct. And that's what I was kind of alluding to in some of these kind of focal seizures. That is where you may have epilepsy or epileptiform discharges in parts of the brain that may not be responsible for your motor functions, but may be important for the way you think or you speak. And sometimes you may have very subtle staring episodes where somebody will just stare into space. If it's in the language area, actually we see some people will actually be talking. They'll stop talking for several seconds and then start off where they left off and won't even realize that they had stopped talking for that period of time. In children with autism, especially those that don't have language, it may manifest as very subtle staring episodes. It's very important in those cases to do what we call an extended EEG or an overnight EEG to see if there is any activity, to capture the episode, and to see how severe the abnormalities in their brain waves are. because of course many children with autism also have what we call, stereotyped movements, or they can have tics, or they can have other types of movement disorders that may look like seizures and may be very difficult to distinguish. And it's very important to find out what the answer is there so that we can treat those correctly.
So you had mentioned that, close to 40% of the population with autism could have some type of seizure activity or a form of epilepsy. Why is that? It doesn't make any sense to me. And why this one particular group has this. The other thing is, it seems as though that I hear often that it happens often in puberty with these, especially boys, from what I read, and I could be wrong, but why such a high percentage?
Yeah, so really great questions, and a lot to unpack in there. So the reason why seizures are so prevalent in autism, we're really trying to figure out. And one of the reasons is we think sometimes some of the same brain disorders that cause autism also cause seizures, some of what we call the neuropathology, or how the brain doesn't work. That is that one of the themes in understanding autism is that we think that the brain, the outside the brain called the cortex, the outside where you do your thinking, is very hyperexcitable, and that every time you have nerve impulses, you have to excite nerves, but then you also have to have a balance that calms them down, right? And what we find is that that area that calms them down is out of balance in regards to the part that excites them. So we find that the cortex, or the part of the brain where you think, is too hyperexcitable. But we find that same theme in epilepsy too. We think that that's one of the reasons why all of your neurons actually get very hyperexcitable, and then may have this seizure-like activity because they get excited too much, and they synchronize themselves and have seizures. So we think some of the same, what we call pathology, or the same reasons why the neurons aren't working in autism are similar to why they're not working in epilepsy. Then again, also we find that children that tend to have genetic disorders tend to have, and autism tend to have higher rates of epilepsy too. Not exactly clear why that is, but we know that that's the case too, that if you have a genetic disorder, which we know occurs in somewhere about 20 or 30% of children with autism, they tend to have higher rates of epilepsy too. So it's not exactly clear why that is, but we know that's a reason. Now, you had another really good question about when you actually see epilepsy emerge in children with autism. And we find there's really two peaks. One is before the age of 5, before the age of 5, and sometimes very early on. So if you have seizures actually predating the autism, very bad, what we call refractory epilepsy that's hard to control, predating the autism, we know that's not a very good prognostic factor. Okay, and in that case, it may be something that's associated with why you have the epilepsy that's causing the autism. And then later on, if you tend to have seizures after you've developed autism, in those years between probably about 2 and 5, we know that those children tend to have what we call partial complex seizures, or these seizures that are only in specific parts of the brain, which can look like staring episodes, which you alluded to. Many times they have these, what we talked about, of these subclinical epileptiform discharges at those ages. And then it tends, after that age, about 5 or 6, you tend not to see new onset seizures in children with autism until you get to the teenage years. And then the teenage years, for some reason, there seems to be new onset seizures in epilepsy. And one of the things that's very worrisome is that when you look at mortality rates of why individuals with autism die, especially in young adulthood, one of the major causes is epilepsy and seizures. So for some reason, we think that there's this kind of second wave of a development of seizures in epilepsy. We're not exactly sure why that occurs. We don't know how to predict that. that tends to be a little bit more prevalent in lower functioning individuals. But at this point, what it seems is that there is this second increase in prevalence. And if it's not diagnosed, it's not treated, it actually could have some real consequences.
And when you bring that up, and I don't know if you know this or not, my son recently got diagnosed with epilepsy.
Oh, I didn't know that.
Yeah, and so we've known each other for many years, and this is something new happened in September. So it's we now have that membership card now, and we hit puberty, and we're one of these, families that were in the 40% bracket now, right, of that. And when, families are listening to this, I can tell you just from my own personal experience, I didn't understand anything to do with seizures up until this. I thought I always had empathy for the families. I thought I kind of understood, but until you've gone through one or multiple types of seizures, I can't even describe it to you. It's because it's just a different animal.
Very scary.
It really is scary. I wasn't home for the first seizure. I was actually at work. I get a text. The ambulance was on its way. He was actually unconscious. It was a very scary moment. But when you're talking about the mortality rate, I was thinking out loud, or not out loud, but thinking nonetheless. I remember not that long ago, a few months ago, when he had his last one. Luckily, it feels as though we found a medication that seems to be working, so we're just holding on to that. But I know I was going to the restroom, and I had just started hearing like kind of a gurgling noise, and he was having a seizure and he was choking. Is that one way that a child, I'm believing, can potentially unfortunately lose their life by choking? Is that, I know falling and hitting their head, we all know about John Travolta's child and the sadness that came about, but for me that was a big moment, hearing that choking, thinking, gosh, if I wasn't going to the bathroom at that exact moment, what could have happened? I don't know.
So I'll say that seizures are very scary. They are scary. For the most part, usually they're more scary than they are dangerous to the individual. But
well, that makes me feel better.
yeah, so they are really scary. But most seizures, most generalized seizures, last for less than a minute, and they self-resolve.
And they kind of reset, it looks like sometimes, and they're all different. Like at least with my son, he's had all different types, it feels, but they'll kind of reset at moments where they'll have a seizure, they'll stop, and they'll kind of just stare. And sometimes that stare, as you said earlier, they last for a while, and then sometimes he'll kind of come back, and he's not exactly how he was prior, but he's not, he seems to kind of get through it and be okay.
Sure, yeah. I mean, they are very scary, so I don't want to minimize them, in any ways. I will say something that's really important. We did a national survey, myself and Jim Adams, a number of years ago now. Now it's probably about 10 years ago. And one of the things, so about 10 years ago, Jim Adams and I did a study, a national survey of families that had children with autism and epilepsy to find out what treatments actually worked best for the children. And other different information. One thing that was very concerning is that we found that only about 50% of the families reported that they were prescribed a rescue medication.
Oh, wow.
The rescue medication is very important, and that is used to stop seizures that go on for a period of time. Many times we say that if a seizure goes on for more than 5 minutes, you want to stop it. Some people are a little bit more conservative and they say 3 minutes. So you have to work with your doctor. But what's most important is that you have one of these rescue medications so you can stop a seizure that goes on for any prolonged period of time. One of the things that we associate with mortality in seizures is something called status epilepticus. And that's when a seizure goes on for a long period of time and can't be stopped. It ends up that the body is pretty robust, so it takes about 20 minutes for a seizure really to start to do damage to the body, which is a very long time.
That's a very long time, yeah.
So we say that if a seizure goes on for more than 5 minutes, to give a rescue medication to try and stop it. Usually that works, not always. A lot of times you'll have a second dose to use in case you need to do that, in case the child needs a second dose. I always tell families, especially if they're new to epilepsy and seizures, that as soon as you give the rescue medication, to call 911. So you have an ambulance there. The child may recover just fine, but you want to make sure that in case they don't, in case the seizure doesn't stop, you have professionals on the way that can give a higher level of medication to stop the seizures. So we want to prevent status epilepticus, and that's really the number one cause of death from seizures. There's also something called SUDEP, or sudden unexplained death associated with epilepsy, which is very scary. And that happens because we think that sometimes the systems that control the heart and the lungs may become unstable when a child has a seizure, or when they have a subclinical seizure that you may not even see. We know that making sure that you take your medications, your anti-epileptic medications, reduces the risk of SUDEP. So it's always important to give the child or the individual the anti-epileptic medication that they need, and not to skip doses, so that they will make sure that they reduce their risk of SUDEP also. During a seizure, you can have gurgling noises, as you mentioned. A lot of times during what we call the tonic phase, when the whole body becomes very stiff, the diaphragm, which is the muscle that controls your breathing, becomes very stiff, and you're not breathing completely. The child isn't breathing completely, and you can see what we call cyanosis, or blueness around the mouth. Usually that's very short-lived, and usually during the other parts of the seizure, there is breathing, although it might be shallow. And usually we don't see a lot of choking as a.
Oh, well, that makes me feel, but I put him on his side just to be that, that's what I did.
Exactly. And so that's really the best, because the one thing with kind of the choking that we would worry about is what we call aspiration. The stomach contents come up and can go into the lungs, and that can cause an infection. It can block the lungs and prevent you from breathing. So what we suggest is put the individual on their side, so that if they do kind of throw up at all, that it comes out of the mouth and it doesn't go back down into the lungs. Of course, don't put anything in their mouth. Many years ago, many decades ago, we used to think about putting something in the individual's mouth to prevent them from swallowing their tongue, so to speak, but that doesn't really happen. So we do not recommend actually putting anything in the mouth, but turning them on their side is a good idea. Making sure that they're in a place where they're not going to injure themselves, where there's no hard surfaces, making sure they're on the floor in some way that they won't injure themselves is a good way. And usually, most seizures only last for about 1 to 2 minutes, and then they stop on their own. If they go on longer, of course, a rescue medication is needed to stop them.
And when I know sometimes too, this has only happened twice. We've had a total of 6 seizures, which 6 too many if you ask me. But, luckily we have great doctors, like yourself out there, helping so many of our communities, and doctors that all learn from one another. But it was really new when the bodily functions, also something for you guys to also know, is sometimes when they have a seizure, they lose bodily functions. They could vomit, they could bite their tongue briefly. I mean, my son did bite his tongue, but it wasn't anything to be too concerned over. More our concern was trying to just get him to a safe spot, to where he wasn't going to hit his head, just to make sure it was over. And then after it was done, we obviously cleaned him up and then got him to a restful, state, and monitored him. But why do they lose why do sometimes they have a seizure, they lose their bodily functions, and sometimes they don't?
Right. So for the most part, that's it's talked about more than it actually happens.
Okay. Yeah, it's only happened at, like I said, we only had that happen that time, or 2 times I should say, but the other ones it didn't. So it was like, you're waiting for it, and then you're like, oh, okay, that didn't happen this time. And I Google stuff, and I get nervous to Google because there's so much information, and you just don't know which is good and which is not so good. So I like to hear from you.
So yeah, I mean, it tends to be the fact that when the brain has this, especially if it's a generalized seizure, so you usually see those in generalized seizures more than focal seizures, and that's because when in generalized seizure, the entire brain has this abnormal electrical activity, and it can send the wrong messages down to the lower parts of the brain that control the bodily functions. And that's what we worry about with what we call status epilepticus, because when that happens, if those messages go for too long a period of time, they can send the wrong messages for breathing and for regulating the heart and the blood pressure. But sometimes we see that those messages go down, especially during generalized seizures, and affect the other bodily functions. But luckily, that doesn't happen all that much. It's more talked about than
Yeah.
actually occurs.
Well, and it's interesting because I don't know if it's just us, but I've talked to lots of other families. It seems as though with autism, there doesn't seem to be one standard type of seizure, even within your own family. So, like with our son, we've had we've had some like that. We've had some that, a little bit of kind of moving, fell out of the ground. Then it was, I don't know, a minute or so later, he got back up and acted as though nothing, even though I know we just had, he almost like drunk falling down is the only way I can kind of explain it.
Yeah.
And then sat for a minute or so and got up, rested, I don't know, a couple minutes, and then went about his day and looked nothing like, the others. But I've talked to other families and they've kind of given me the same kind of thing. It was like, oh yeah, that's how my son is too, or my daughter is. There's not like one type. So even when you have seizures, there's not always like the same type of, is that normal with epilepsy in general, or is that just what we see in the autism community?
It's probably a little bit more prevalent in the autism community. So standard seizures that tend to resolve over time. Yeah, they seem to be what we call stereotype. They're always almost the same way. But many times when we have complex seizures or complex seizure phenomenons, they tend to be like this, where you see different types of seizures at different times. And a lot of times families think that there might be some meaning to that, like it might be a progression or improvement. And for the most part, it's just that it manifests different ways. And one of the reasons is that most of the time we say what we call these multifocal seizures, where you have multiple parts of the brain that have this abnormal seizure activity. So it may be that the seizure starts out from one part at one point, or starts out from another point at another point. So you're going to see different manifestations. Then whenever you have what we call these partial or focal seizures, the danger many times is that they can spread. And when they spread throughout the whole brain, you have something called a secondary generalized seizures. So some people have what we call generalized epilepsy, where they always have seizures that affect the whole brain. Other times you can have what we call secondary generalized, because some of the focal seizures get together and they spread throughout the brain and then cause the seizure to be throughout the brain. So you can see in those individuals both partial seizures, that depending on where there might be one part of the brain having a seizure, or it may manifest with the whole brain having a seizure.
Now, with children, earlier you had said regarding seizures that you have this kind of seizure that we're talking about, and then you have other ones that are provoked, I believe was the word you used. So I was thinking of when I was a kid, and I've had a couple since I was an adult, but they were provoked by high fever, right? And so when you have a child with autism, do you have to worry about a provoked seizure as well if they already have, let's say, epilepsy? Now with a high fever, is that something also that we have to have some type of concern?
So all the time, so for care for seizures, definitely we know that any type of physiological stress is going to decrease the seizure threshold. So things like fever, just illness, you don't have to have a fever all the time, but any type of illness, other things like poor sleep, poor nutrition, not being hydrated in the heat, all of these things, anything, even psychological stress can provoke seizures. So anybody that has epilepsy, not just children with autism, we say they have to be especially careful about keeping themselves well.
That's good to know. Now, my next question is regarding EEGs. So I know many families out there, we've done them as a prevention or maybe just an insight into our child's brain to see maybe what's going on. I know in the biomedical community that it's recommended at least to have one or two within that child's time frame or life of and then if no seizures happen, that's fine. But you kind of, if you're watching and your family listening, it's really important to kind of know what is going on in that child's brain, and to do a minimum of a 24-hour EEG was what was recommended to us. If you can do longer, I hear that's better. I know some insurance may or may not cover longer. I hear 72. You might have a different idea, but I hear 72 is the best. I know most insurances don't want to cover that, unfortunately, so a lot of us do 24-hour, EEGs. Now, here's my question. I've talked to many people where we've had totally fine, what they call clean EEGs throughout that child's life. I've had 5 24-hour EEGs done with Jackson throughout his life. I had one done 30 days approximately prior to his big seizure. We actually knew he finally had a seizure. I had that one done because I really felt there was some, and we'll get into this as well, some symptoms that I thought might be looking like seizures, even though it wasn't the quote unquote seizure. So I thought, well, let's do another EEG and let's see what we see. Never had he had anything irregular on his EEGs. A top neurologist at one of the hospitals here in Southern California looked at us and said, this child does not have seizures. The child's not going to have seizures. Everything is fine. I wouldn't even waste any more time doing EEGs. Approximately 30 days later, the ambulance picking him up, and he had a full-blown seizure. So you can only imagine my thoughts to that neurologist, right? Because I thought, I knew, as a mom, you feel like this instinct, like something's not right. And I think as mommies and daddies out there, we got to follow our instincts and really get these doctors like yourself who do listen to us, but not every doctor does, right? So why do we have clean EEGs? And then our children are having seizures still. It gets so mind-boggling.
Yeah, I usually most of my patients I recommend a 24-hour overnight EEG.
Mm-hmm.
I think if you have a clean 24-hour EEG, that's pretty good.
Mm-hmm.
Now that's with the caveat that many times you can have epilepsy and you can have normal EEGs.
Mm-hmm.
Just think that if there's something to catch on the EEG, probably 24 hours is pretty good to catch something.
Mm-hmm.
You may still have a clean EEG and still have epilepsy. I usually recommend overnight EEGs for kids that have staring episodes or have really poor language development or
Mm-hmm.
other cognitive symptoms. Other kids with autism that don't have any staring episodes, that are pretty well, at least somewhat interactive, that have language skills, that have okay language skills. I usually don't do an overnight EEG. One of the things we did do one study where we looked at kiddos with subclinical discharges, and we found that most of them had speech or language impairment.
Okay.
So if the child doesn't have speech or language impairment, and they don't have staring episodes, I may not do an EEG. But for most young kids, I will. Most young kids. Now, you have a really good point. I get asked this a lot about older children,
Mm-hmm.
because there's this idea that, there may be this onset of epilepsy. And many parents want to do an EEG just in case for older children. But it really seems like the literature supports that the abnormal EEGs tend to normalize in late childhood,
Mm-hmm.
and they tend to be more normal.
Even if they could have seizure activity.
Yeah. So unless they're having symptoms where they have
Mm-hmm.
staring episodes, let's say an older kid with staring episodes, or again, poor language development, or some reason that's going to make me do an EEG, I may not even do an EEG, because what we find is that the new onset seizures later on just don't seem to have any rhyme or reason as far as having really a signature of abnormal activity on the EEG.
Well, then that makes sense for us then of why our EEG was clean, and yet
That's a typical, and I'm sure the neurologist was trying to do, the best and give you the best advice. But one thing, if you work with enough children with autism, is that you never say never.
yeah.
Every child's different, and they always fool you. So,
Yeah, the minute you think they're going to turn left, they're going to turn right, do a U-turn, go back left, and turn right again. Oh, and this neurologist wasn't somebody that works with autism. This was just a general neurologist at the hospital that were considered, somebody we wanted to have a second look at, and to make sure, and, it is what it is, and, we are where we are, and we just keep on moving forward. Now, my next question is, this medication that every family is giving to their children with autism. So when I started learning about seizures and epilepsy, and I just don't know anything really, I'm still learning, which I love these summits because I get to learn along with all the parents, right? So there's so many medications out there, right? And and it's like you don't know which way to turn, and we can try this one, but then maybe you need a little bit of that one, and then you get this one, and well, maybe that didn't work, but maybe we got to up the dose. And how, as a specialist in this, how do you know which drug is going to work, and do you have to be on these drugs for the rest of your life, and all that, all the above?
Right. So I think now, we have the advantage that we have a lot of new medications that are very safe. So many of us, I think, try to go with the first line medications as far as safety. And that may or may not be the best thing to do. So I'll tell you that in our seizure survey study that I did with Dr. Adams, and also we also did a systematic review on the literature on treatment of seizures and autism many years back as part of a seizure think tank, and we found that the drugs that had the best efficacy or were thought by parents to be most useful were Depakote, Lamictal, and Keppra.
Okay.
And that was kind of when Keppra was one of the new drugs. So now we have newer drugs, but we don't have any data on how they work in autism. So I usually start with one of those three drugs. Each one of them has its positives and negatives. I know that a lot of families don't like the idea of Depakote because you need to have many times multiple blood tests because it affects the liver and the blood cells and such. Lamictal is a very good drug. It's very helpful, although I've seen some children have the opposite effect because it's supposed to be behaviorally stabilizing, and sometimes it isn't for some reason in some kids with autism. So you have to be careful. And then Keppra is a very safe drug, but there's many children with autism that behaviorally don't tolerate it very well. I usually try it. I think it's worth a try because it doesn't have any serious side effects. So I think it's worth a try. All those medications in our seizure survey were rated as actually controlling seizures very well, but they all seem to have some negative side effects on some of the other aspects of behavior or sleep or other things regarding autism. There's other treatments that are not anti-epileptic medications, like the ketogenic diet or the Atkins diet, which tend to be not only help with seizures, but seem to have at least some data that suggests they also help with autistic behaviors. So there's other possibilities of other treatments that can be used. It's important to be on some type of anti-epileptic medication, I think, if you have seizures, just because of what we talked about, the danger of status epilepticus, the danger of SUDEP. So I think that it's always important to choose some type of anti-epileptic medication, guided by your doctor. And many times you do have to try certain ones to see what is best for your child. Sometimes, and I think this is just a theme in autism. Many children with autism just don't react to medications like other kiddos, and you can't predict it. So you have to be very careful.
Yeah, it's I know with us, we were on one, it seemed to be working, then I don't know what it was, almost a month later it didn't, we had a seizure, so then we added something else that seemed to be working, then that didn't, then we upped this part of it. And now, I'm hopeful. We've been seizure free for a few months, and that's always a good thing. But I do agree I think that there's side effects, and you get other behaviors at different points. And now we're working on that. Do you see aggression, or sleep issues, or, speech issue? Like, do you see, what are some of the things you see as side effects, with those that are newly on medication, or is there just, drowsiness? I'm not sure.
Yeah, so the major side effect of almost any anti-epileptic medication is drowsiness,
Mm-hmm.
Tiredness, slowing of cognition, tremor, unsteadiness.
Mm-hmm.
So those are kind of general side effects. In individuals with autism, yeah, we tend to see more behavior. Sometimes we see aggressive behavior, irritability,
Mm-hmm.
poor attention, poor cognition, poor language. So whenever that happens, you have to watch for that. So you have to watch for that carefully and understand that can be a side effect. And many times you have to change medications
to help this. And I think that's important for families to know, because I've talked to a lot of families, and they didn't know that maybe like they got rid of the seizures, but then all of a sudden this other stuff started popping up, and then they didn't even put two and two together to realize, oh, wait a second, the medication might be causing this. And then they did switch medications, and then all of a sudden the seizures were gone and these behaviors were gone. And I think often you're just thinking of seizures be gone, and you're not thinking of this other stuff that could pop up.
Yeah, and it can be medications. It can be other things. So there's also a phenomenon called forced normalization that I think people didn't understand. And that is when you have a kid with really bad epilepsy, that the brain has so much seizure. And this is a child, let's say that if you do an EEG, they have lots and lots of seizure activity going on. And then you treat that, and the seizures go away. But their behavior just becomes terrible. And there it's I don't think everybody agrees on it of why that is, but it may very well be that if the brain isn't working at all, you may not see much behavior, but then you actually solve the problem of having all the seizure activity in the brain, and the brain kind of wakes up, but it hasn't matured at all, and suddenly it just has all this input from the surroundings, into a very immature brain. And so you can see a lot of anxiety, a lot of behavior, a lot of attention deficit, what looks like attention deficit problems, which you may need to manage with other medications. So it's not as simple as, well, one medication, can be causing that. And sometimes we actually see by treating the seizures, some of these behaviors arise because you're actually kind of opening up part of the brain that, was offline for a long period of time. And now the brain has to actually mature.
Now, isn't that fun? It's like, we already got this, and we go, I'm always joking, like, I'm so tired of these membership cards. Give me one to Club Med. I don't want any more of these other ones. Because we're constantly, I feel like it's like this kind of, I almost feel like it's like a boat that, like, they keep springing a leak, and then we, like, fix one leak, and then boom, another leak happens. And it's just this constant, like, we're on the middle of the sea just trying to, like, survive in this boat. And we're just pushing out all the different leaks. And so, but, what I love is that I know I don't know all the answers, and I know a lot of people watching, they're feeling the same way I am. But the thing I love is that there's doctors out there like you, that we're not giving up on people like us, saying, hey, I don't know which one it's going to be, but we're going to go ahead and try this. Okay, now let's go ahead and try that. And we live in a day and age where there's lots of options, and so we don't know what's going to work for every single person. And so I wish we did. It would be so nice if you're like, and here's the combo, 714, done. But unfortunately, it doesn't work that way. So I want to talk a little bit about CBD, only because it's a big hot topic. When we talk about seizures, people are talking about CBD. And so, what is your take on CBD?
Yeah, I think it's a really promising area of treatment for a lot of things. We know that in neurology, it seems to be helpful for certain indications. One of the promising indications is seizures and epilepsy. But I think we really are kind of in the infancy in understanding that. I think that, of course, one of the things I'll say, it's important for parents to understand the difference between CBD and medical marijuana. Okay, CBD is the non-psychoactive part of the plant, and it's from hemp or and and that's important because we think that when you add some of the psychoactive portions like THC, it's kind of a wild card as how it will react. So I think most of the data we have is on CBDs and not medical marijuana. So I think you have to be really careful about that, about using medical marijuana, because it's very uncontrolled and it has many different mixtures.
You don't know I know lots of people that are on it and it's helpful. And I know that sometimes you just don't know for the right dose, and they don't know the right dose to give. And it's one of those things where they'll say, we'll try this, and then, okay, well, go this way and then go that way, and until you can kind of find your right balance. But you're right,
and the products aren't regulated, so the balance may be different, next month as it is, this month. So I would caution against using medical marijuana. Now CBDs I think are somewhat promising, and then I think you need to also be aware about the laws in the state. So that's always important. You don't want to get yourself in trouble, with using any of these products. CBDs, if somebody is to use CBDs, they have to realize that some companies have something called a certificate of analysis, where they'll actually tell you what's in the CBD. So you'll know exactly what's in the product, whereas there'll be other companies that won't give you any analysis. And I know they just did a study here in Arizona for some of the medicinal products. And they actually found that I think 5 of 7 of the products had absolutely nothing in them.
Oh my goodness. And they're charging a fortune for some of these families.
That's what they were saying, is that, they're charging a fortune, and families are paying thousands of dollars, and they're getting absolutely nothing.
Wow.
So if you're going to use any of these products, of course, it's good to go with companies that actually will give you a certificate of analysis. My advice is not to go it on your own. That it's become so popular. There's many clinical trials for CBDs around the country at many universities and non-university research centers. And if you can get into one of those clinical trials, it'd probably be best, because it will be controlled. There's a quality product. That there's somebody with knowledge that's going to be prescribing it. And you're also going to be contributing to the knowledge that we know about, so that we can know how to use these products in the future.
And I think it's definitely very hopeful. I mean, we've all heard of Charlotte's Web. We've all heard, that just seems to be the most popular one. I know there's many others that are out there. Even the Autism Hope Alliance, we have partners that, carry the different brands. But for me, when you read a story and you hear somebody that nothing worked for them and then it worked, it's something similar with all autism, and I'm sure other, different challenges that people have. And the thing is, though, it's not a one size fits all. What I'm excited about is that there is hope out there, and there's these products that are coming to light, and, more companies are having to stand up and say, yeah, this was in my product. And because there's families and doctors like us out there saying, hey, you know what? Stop playing around with our kids' health. We're paying you all this money. Give us a good product. Maybe it will work. Maybe it won't. What I do love with the thought about CBD, though, is that I feel if it does work and that's something that they can take, gosh, I feel like what a better way to go if that works, But again, we have to learn more. And for those that it is working, I just feel like you won the lottery, you won the jackpot, because you just don't. I know with our son, it's like we try this, and some things stick and some things don't. It reminds me when I was in college and I'd make pasta and I'd throw it to the wall to see if it stuck, and most of the time it didn't. It's kind of in that same situation. I think seizures and autism are, a very, very scary thing. And for me as a mom, I just keep trying to learn as much as I can, I know prior to seizures, I said, I don't want to know anything about it. And, I've been to, I don't even know how many conferences. Of course, I've heard, the whole time I've been in the autism world, but I purposely didn't want to learn a lot about it, because I said, well, I'm not going to be in that group. So I don't even want the universe to think I want to know about that, because I don't want to have anything to do with that. And here we are. Now, my last question is, do you have to be on medication for the rest of your life once you quote unquote get that label of epilepsy?
Sure. No, and well, we know that in typically developing children, many times after you've had a seizure, after you've had two seizures, of course, usually the way we treat seizures in typically developing children is if you have one seizure, we know that you're very unlikely to have another, so we usually don't treat them. If you have two seizures, that's the definition of epilepsy. We'll start on a medication, and then in 1 to 2 years, we'll repeat an EEG to see if it's clean. And then if it is, take the child off of the medication, and to 70 to 80% of the time, they'll never have another seizure. Of course, it tells you about how predictive the EEG is. Of course, it's not perfect, but it gives you a good indication. And so it depends on the type of seizures. There's many children with autism that will have seizures that will only last for a period of time. If they're well controlled for a period of time, and you repeat an EEG, and it seems to be normal, and the child doesn't seem to be having any more seizures, then it's definitely something to try to stop the medication. So not everybody has to be on epilepsy.
Do you have to go low and slow off the medication?
Usually taper. Yeah, it's always a good idea to taper it off slowly.
Well, that's a very positive note. That was something I didn't know till right now. I mean, every time I'm giving his meds, I'm like, oh my goodness, does he have to do this the rest of his life? I'm really hoping not. If you know me, I'm from the natural world, and I believe in RX medication when you need it, and clearly that's why I'm doing what I'm doing. And but I would much prefer. I think nobody wants to be on medications the rest of their life, So it's not something.
It's a good idea to be on medications you don't have to be on, but if you need to be on them, they're there,
Exactly.
and they're important when you need them.
Absolutely. Well, if you guys have loved, I've learned, clearly I'm a little biased because I'm in this world of seizures and autism. But I hope that you guys understand that this is something we all need to learn about, because regardless if your child is not in this membership club, I hope they never are. I truly, truly do. But I think it's important for you to look for signs and symptoms, and then know what to do if you feel as though your child might be having a seizure. It's always good to, check that off the "this is not happening" box, versus later going, gosh, I wish I would have, learned more about that. Obviously I knew somewhat about it, is why I want to do the EEG and that kind of thing. But we don't want anybody in this membership club, but we're here. And, with 40% of us most likely at some point potentially going to have a seizure at either, prior to 6 and maybe in puberty, we got to learn everything we can. And so if you guys want to, have Dr. Frye in your living room, and because your significant other didn't get to watch this week, or you want your family member to watch it, or your friend down the street really should have watched this, super easy. All you have to do is go to autismhopesummit.com. You can buy the whole summit of over 25 top leading experts in their field talking about things that we all need to know about. Now, here's the best part. Every single time you go to buy part of the package, or you buy the packages, those dollars raised go back to the Autism Hope Alliance, and it goes into our nutritional scholarship fund, so we can continue to help more and more families across the world. I know last year we had over 160 countries watching or listening to our summit. You can even get last year's summit and the year before, so you have a whole amount of information that are at your fingertips, because we're here to help you guys in our best way. So Dr. Frye, I know that you are so busy. I know trying to even get this interview was just like, I was like sitting there going, oh, I hope we can have him. I hope we can have him, because I know you're just all over the world. What is the final message you want to leave people with today?
Well, I think what you were saying, there's always hope. I think you always have to be pushing forward to really make sure that you find the best thing for your child and for your life, and to make your life and your child's life as best as you can. And I think there's always reasons to go forward, always reasons to look for answers and to search for answers.
Absolutely. And guys, again, just remember, there is always hope. We keep saying this every single lecture you're watching right now. We're saying, every person's saying the same thing. There's hope. There's hope. This whole summit is called Hope with a Plan. We're actually giving you those tools. So we're not giving up. Just know that these doctors aren't giving up on us, and we're just going to keep on moving forward, because the only way is up, right? So thank you guys for watching, and until next time. Bye, guys.